screen. Okay. Is everyone seeing that? Yeah, okay. We have no disclosures to report. And I'll be talking about managing co-occurring alcohol use disorder. So in this case, co-occurring referring to your patients who have co-occurring opioid use disorder, but this is really pertinent to just alcohol use disorder in general. And imagine you all are quite familiar with this already, so definitely would love to hear any questions or comments you have. And if I don't notice them through the chat, please do remind me. The objectives are to learn the signs and symptoms of alcohol withdrawal syndrome, to learn ways to properly manage alcohol withdrawal, and to become familiar with FDA-approved medications and some that are off-label and psychosocial interventions for treatment of alcohol use disorder. So we'll start with the case, just to kind of give a little bit of clinic picture here. So you have a patient, Ms. A, who's a 41-year-old female with a history of hypertension and opioid use disorder. And she presents to clinic for routine follow-up on her blood pressure. She's been taking her buprenorphine and her hydrochlorothiazide and lisinopril for blood pressure, and tries to follow low sodium diet and regular exercise. She did quit smoking tobacco 2 years ago, but she does report daily alcohol use. And on physical exam, her blood pressure is 154/98, and the rest of her exam is normal. So you're worried about her blood pressure and are wondering if it could be linked to her alcohol use. So how do we determine if she has a pattern of risky drinking or if she actually has an alcohol use disorder? So we'll just review some definitions here. It's important just to remember our standard drink amounts. So in the US, a standard drink is 0.6 fluid ounces or 14 grams of pure alcohol. And you can see depicted here a few of those. And this is important too, because if your patient reports having 1 or 2 glasses of wine, let's say every evening, you want to know, are those 5-ounce glasses or are they larger? Because that would help you kind of quantify their risk based on the amount. So what is risky drinking? The National Institute on Alcohol Abuse and Alcoholism defines it as these quantities of alcohol as low risk for developing alcohol use disorder. And again, this is in adults who are not pregnant. So for women, this is no more than 3 drinks in a day and no more than 7 drinks in 1 week. So importantly, it's both of those, right? So if they have 2 drinks every day of the week, that's going to total more than that 7 in 1. And then for men, no more than 4 drinks in 1 day and no more than 14 drinks in 1 week. So this is important to distinguish from alcohol use disorder, which we'll get into next, because this is purely about the amount. I'm going to touch upon SBIRT, which is screening, brief intervention, referral to treatment. And this is a really important evidence-based intervention, has a grade B from USPSDF, which recommends that we screen for unhealthy alcohol use in adults, including pregnant adults, and provide brief counseling interventions for those who are engaged in risky or hazardous drinking. And this can be administered by many health professionals in different settings. The evidence is strongest in primary care, though I believe this was first developed in ER settings, and it involves the 5 A's approach. So ask about their drinking, advise, assess their readiness to change, assist if they're ready to make a change, and then arrange their follow-up for that. And the sessions can last anywhere from 50 to 20 minutes. Importantly, again, because of that grade B recommendation, these are covered by Medicare and Medicaid, and the goal is to reduce the risk of negative consequences of use. So this is really most beneficial when you catch people in that more early zone when they're engaging in risky drinking and haven't yet developed alcohol use disorder. So how do we screen for risky drinking and alcohol use disorder? And it's really recommended to start with a single question initial approach about heavy drinking. This is recommended by NIAA, and that is, how many times in the past year have you had 5 for men, 4 for women, or more drinks in a day? And this is going to be your initial screen, where if it's negative, then you move on. But if it is positive, you want to assess their risk more using a validated tool, such as the audit or audit C, which we'll have an example of here. Also, just to touch upon for geriatric population, the MASG has higher evidence, and the CRAFT for adolescents would be the validated tool for that population. And just to touch upon that craft tool, you could consider using a lead-in about friends use, especially for younger adolescents. And you really want to avoid ambiguity. So being very direct then, after your initial lead-in, during the past year, did you drink any alcohol? And any youth who has a positive answer should then be asked the following questions. So asking about being in the car by someone using the alcohol or drugs to relax, using alone, ever forgetting while using alcohol, have family or friends asked you to cut down, and have you gotten into trouble while using? So we'll return to our patient that we saw in clinic, and she responds yes to that first screening question regarding heavy alcohol use once in the past year. So then you proceed to administer the audit C, and she scores a 7. So we'll look at that. You discuss it further, and you learn that she does have significant fear of stopping her use because she has had withdrawal 2 years ago, and she resolved that by returning to alcohol. And it's interfering with her home life and work, and she's asking for your help. So here's the picture of the audit C. This is how she answered. These are 3 questions, so also relatively quick. How often do you have a drink containing alcohol? And she circled 4 or more times a week. How many drinks containing alcohol do you have on a typical day when you're drinking? And then how often do you have 6 or more drinks on one occasion? And you can see here that a score of over 4 identifies, of at least 4, identifies 86% of men who are drinking above recommended levels, and they may meet criteria for alcohol use disorder, and over 2 for women. So she has, based on this, we're going to assess further for alcohol use disorder because she's meeting the criteria for risky drinking. And the DSM-5, has 11 criteria, just as it does for many substances for treatment for identifying substance use disorder. So for alcohol use disorder, we're really looking at, there we go, basically having at least 2 of 11 criteria, and then the number that they have would kind of determine their severity of this use disorder. And they're really, you can think of them as grouped into that cravings, compulsions for use, and consequences of use. And then also tolerance, again, which is needing to drink more to get the same effect, or having a decreased effect if you continue with the same amount, and then withdrawal symptoms. So based on what the patient told us about the withdrawal before and having some negative consequences, we already have, in this case, met criteria for an alcohol use disorder. So what treatment can we offer? Treatment rates in the US are, and really globally, are pretty dismal. The data shows that only 6.7% of adults and 5.2% of youth with alcohol use disorder in the past year received treatment. Less than 1 in 10 people in the US with a diagnosis in the last year received treatment of any kind. Over 90% of community programs outside of the VA offer only group counseling and referral to AA, so don't involve medication or more sort of integrated care, which we'll talk about the benefits of that. And importantly, racial and ethnic minorities experience barriers to mutual help groups, and in general demonstrate lower treatment utilization, especially by women. So even more need to focus work there to help people in treatment, get into treatment. What are the options? So you think of the treatment option for alcohol use disorder in terms of 2 main aspects, and with medication management. You're going to be making sure you're managing any acute withdrawal that may exist or be imminent, and then we'll talk about relapse prevention and medications for that. So in terms of the acute withdrawal, initially in your decision tree, right, you're determining if they are safe to have a withdrawal in the outpatient setting, or if they need to be inpatient. And this is in part determined by just the severity of their withdrawal in that moment. And we'll look at a CUS score next, which helps sort of break that down. But also their history. Have they had a prior seizure? That's really the main thing that we're trying to avoid, because that can be fatal. And so prior seizure, other things can be uncontrolled medical comorbidities, not having support at home to go through the withdrawal, pregnancy. And then once you've determined if they're how you can manage their withdrawal, what is the standard of care is a brief benzodiazepine taper. And really this should be brief, over 5 days. And you can consider other medications that are non-benzodiazepines. So there is some evidence, certainly for carbamazepine, and also some evidence in mild withdrawal cases for higher dose gabapentin. But again, this is more for helping the other related symptoms with withdrawal, as opposed to actual seizure prevention. And then next, we'll go into talking about FDA-approved medications for relapse prevention. So being naltrexone, which comes in two forms, acamprosate and disulfiram, and then touch upon the off-label use of a few other medications. This is kind of small, but this is just a CWA scale. You may or may not have these in your settings, but basically this is a subjective and objective scale that's looking at the signs of withdrawal. And really what we see is if someone is scoring higher than a 15 on the CWA, then they're definitely going to be needing medication to help manage their withdrawal. And really, if they're higher than 19 to 20, it would be recommended to be inpatient. Inpatient options can be limited, I realize, and so oftentimes we struggle with that, but based on severity and likelihood of going into withdrawal seizure or delirium tremens, this is a key thing to assess. So in terms of these medications for withdrawal, again, you can see there's a lot of evidence as far as the benzodiazepines for prevention of withdrawal seizure when compared to placebo. We see this in the 2010 Cochrane review of 64 RCTs. There's insufficient evidence for the use of anticonvulsants. However, good evidence that carbamazepine can be more effective when compared to oxazepam and lorazepam in treating some aspects of alcohol withdrawal, and it can also help decrease drinking extent after a detox. And also there may be certainly a place for the use of this in patients who may have a co-occurring sedative hypnotic use disorder. And there may also be a role for gabapentin, as I mentioned before, in mild withdrawal. So we assess our patient further and administer the CWA, and she scores a 12. So in that moderate range, not clearly needing medication at this point, but she may. She does not have a history of head injury, seizure, and she's not pregnant, and she has support at home. So you review the options of inpatient versus outpatient detox, discuss the risks and reasons why she would, need to present to the ER, but we agree with her decision for outpatient detox. So she returns after a successful taper at home, so fast forward a week, but she reports strong urges to drink. So at this point, we'll talk about how we can help with that prevention part of the tree. So what are the medications for alcohol use disorder for relapse prevention? And really the standard is naltrexone. This has a large body of evidence. Naltrexone is an opioid antagonist, so that functions by blocking the effects of endogenous opioids that are released by alcohol consumption. So working on that new receptor, the same one that the opioids work on. And naltrexone has been also FDA approved for opioid use disorder, but in its oral form is effective for alcohol use disorder rather than opioid. Its FDA approved dose is 50 milligrams. However, there's the long acting form, otherwise known as Vivitrol, and that's given in a monthly injection. Again, because it's an antagonist and blocks that same receptor that opioids work on, it's precipitated withdrawal. And I have had it happen more than a few times that I'm thinking I would want to use it, and for a moment forget that I'm seeing my patient who's also on buprenorphine, so like this patient here in the case. So it wouldn't be something that we could offer someone who's on buprenorphine or another opioid agonist or partial agonist. You do need baseline monitoring of the liver, and then shortly after starting, and then quarterly, and then can extend monitoring of that. It can be started while someone's still drinking. It's been shown to decrease craving, and it decreases that euphoria that's experienced with alcohol, again, because of that blockade effect. And it decreases the chance that if someone has a drink, that it would turn into an extended relapse. And it has a good body of evidence. So Cochrane review of 50 RCTs, Nearly 8,000 patients showed that it decreased relapse to heavy drinking to 83% placebo risk with a number needed to treat of 10, and decreased drinking days by 4% and heavy drinking days by 3%. So a great option for many patients. The combined study was the largest controlled pharmacotherapy trial for treating alcohol use disorder. Happened at 11 sites in the US, and it randomly assigned patients to placebo plus minus acamprosate plus minus naltrexone, and then all with medical counseling in the provider visit. And half of the patients have received up to 20 CBI sessions. And what they found was that those with naltrexone medical management alone, and then those with placebo medical management plus the CBI, had the most substantial decrease in days drinking. So this is really where our recommendation for treatment in outpatient clinics of alcohol use disorder with naltrexone comes from. We'll talk about acamprosate briefly. And acamprosate's an amino acid derivative that increases GABA transmission. It's thought to stabilize the glutamate receptor, and so also can help promote abstinence by alleviating physical and psychological symptoms. It's a little bit more tricky to dose rather than that once a day dosing or the monthly injection from naltrexone. This one is 2 pills 3 times a day. That dosing regimen can be very hard. So sometimes if patients are more able to take it in twice a day dosing, then they can split it into 3 pills 2 times a day. It's not metabolized by the liver. We do need baseline renal function. And again, this is a great option for someone who may be on an opioid agonist or partial agonist because it's not blocking that receptor. A Cochrane review of 24 trials showed acamprosate decreased relapse to alcohol when compared to placebo with a number needed to treat of 9. And its most important role seems to be in preventing relapse in someone who's already abstinent from alcohol. However, it is safe if someone is, it does drink with this medication, it's still safe. And then this medication, Disulfiram, otherwise known as Antabuse, again, this one has been around for a long time, doesn't have such good evidence. It inhibits aldehyde dehydrogenase and creates that awful feeling reaction if someone comes into contact with any alcohol. Signs of this can include flushing, tachycardia, palpitations, nausea, dizziness, confusion. Really need to monitor liver function. And it's really contraindicated if someone doesn't have a goal of total abstinence. Also can't be started within 48 hours of the last drink. And again, doesn't have too much evidence, but it's likely best if taken under supervision. So for some individuals, this may be a beneficial option. And then these are some off-label medications for alcohol use disorder. Topiramate has some evidence, have to be cautious as far as potential side effects, kind of starting slow and then increasing up as tolerated. Women have to be on birth control. And it may have, again, significant side effects that may not be tolerable for the patient. Gabapentin has a fair amount of evidence as far as second line medication. There's a meta-analysis of 7 RCTs that showed effect on the percentage of heavy drinking days. And you do have to have some caution with gabapentin. It has some potential for misuse, so just want to monitor your patients. The current APA guidelines, again, naltrexone and acamprosate are recommended for treatment of moderate to severe alcohol use disorder. And then they do suggest the use of topiramate and gabapentin in patients who have this level VUD, but usually after first trying naltrexone or acamprosate, and steer away from disulfiram as first line treatment. So how do you decide which medication to take? It's important to consider coexisting medical comorbidities. So again, patients with opioid use disorder on treatment, medical treatment, likely would not be able to have naltrexone. And then thinking about liver and kidney function in terms of how both naltrexone and acamprosate are cleared. You want to ask about their prior experiences with treatment. They may have had success or problems with some of these medications, and that can help guide you. Also, their ability to take medication at a certain frequency. They may do better with a monthly injection than, say, a medication that they have to take daily or multiple times a day. Also want to remember to consider their psychiatric comorbidities and need for treatment for co-occurring mood and other substance use disorders. So even though antidepressants alone have not been shown to have effect for alcohol use disorder, there is evidence that sertraline with naltrexone in patients who have dual diagnosis with these, that their rate of abstinence was higher when patients were on both than with either alone. And then just in the last couple minutes, talk about some behavioral interventions for alcohol use disorder. So brief intervention has a large body of evidence. There's a meta-analysis of 34 studies, 15,000, upwards of 15,000 participants that showed that receiving brief intervention, that these folks ingested 20 grams less than those in the non-intervention group after a year, so over a fairly large amount of time. And there was little difference though shown on the frequency of drinking or binge drinking days. And the features again of brief intervention, I know that Dr. Maley goes into this in much better and great detail in her talks, but these include feedback, responsibility, advice, providing a menu of options, and then expressing empathy and supporting self-efficacy. And typically these lead to a 20 to 30% reduction in heavy drinking with a significant effect for up to 2 years. As always, our motivational interviewing skills matter. So over 32 studies have shown benefit of MI in the treatment of alcohol use disorder. It's been found to be most effective in the first 3 months and with younger populations who have occasional heavy drinking but low clinical dependence. And then mutual help in AA, certainly increasing AA attendance has been shown to increase days off alcohol at both 3 and 15-month follow-up. However, a Cochrane review of 8 trials didn't show efficacy as a standalone intervention. So really want to do this along with medical management and other support. And then family involvement, if the patient does have family who they want to have involved and are willing and supportive, then this is a great one. It's been shown to reduce drinking in 5 different trials. So certainly if that is an option, something to keep in mind. So in closure on our case, we've decided to obtain baseline renal function tests because she wants to start a Camprasit. And she is pretty much just go to the target goal, the Camprasit of that 666 milligrams 3 times a day. You encourage her to keep taking the medication, and she agrees to meet with your clinical psychologist for CBT. And at her 1-month follow-up, she reports she had 1 lapse last week with a glass of wine, but it did not lead to a relapse, and she hasn't had any alcohol since. And her blood pressure is also normalized, so that was helpful. She's screened positive though for depression, and after further evaluation decided to add sertraline to her regimen. And she reports improvement in her mood and the length of time off alcohol. So in summary, we'll need to screen youth and adults for alcohol use disorder on a routine basis using our validated tools. We want to be able to diagnose risky drinking and alcohol use disorder and treat promptly. So hopefully the next time that they give us those numbers of adults in treatment, we can see that that's gone up. Alcohol use disorder is one of the most undertreated health conditions in the US. I think it's like 30th on the list of chronic conditions, but it does account for significant morbidity and mortality. We want to assess withdrawal risk and recognize whether a patient needs to be inpatient versus outpatient for their acute detox, and be able to counsel patients regarding their different treatment modalities for alcohol use disorder, prescribe indicated medication, or refer to other support as possible and as they're willing. So I'll stop there and just see if there's any